Okay, we're back. And so here's our diagram. We're going to talk about now the other two kinds of pulseless arrest. Actually, I probably should have mentioned that from the beginning. So, pulseless arrest comes in four varieties. There's number one, which is our V-fib, number two, which is our pulseless VTach, three is asystole, and four is PEA. So asystole is no electrical activity in the heart, and hence no mechanical activity. PEA is there is electrical activity, but no mechanical activity. All right, so we can use our same algorithm here, but make a few changes to account for what we need to do for these rhythms. Okay, so we're going to do the same thing. We're going to call for help, put them on CPR, put them on monitor, check a rhythm, and now at this point, remember our only shockable rhythms are V-fib and V-tach. So at this point, if you have PEA or asystole, you don't shock them. And you go around the first time, and you put the IV and the O2 in. And then the second you do again, check a rhythm, still probably the same thing, ACLS or asystole or PEA, and you don't shock them, and you go around a second time and you're going to give one of these drugs. I would probably give this one for asystole then. For PEA or asystole, let's do this. Okay, so for PEA or asystole, give epinephrine. And then you go around again, and you again check a rhythm. You're probably not going to shock because it's not going to be a shockable rhythm. And then this is only for V-fib and V-tach, because remember, this is an antiarrhythmic. And right now, either we have a decent rhythm but no electrical activity with PEA, or we have no rhythm whatsoever with asystole. So you don't give amiodarone for asystole. And the next time around, you're going to go to the 5 H's and the 5 T's, which is what we classically do for PEA. Now, there's a few differences here than what we used to be taught. Okay? Now, with asystole, we used to be taught to give atropine. And the reason why you gave atropine for asystole is just in case it was a really, 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 really slow bradycardia. But that's just been shown not to work. So guess what? No atropine. Same thing for PEA. After doing the 5 H's and 5 T's, they used to recommend also giving atropine. So no atropine here for PEA. And the other thing that you want to consider is with asystole. If you see this on the monitor, it looks like asystole. But the thing is, you want to check a second lead, because you might have actually maybe a fine V-fib, and the amplitude wasn't big enough to pick it up in that first lead. So check a second lead. Or maybe one of the leads is off, and so that's why you're getting a different rhythm. So fine V-fib is a lot different than asystole. Remember, we don't do a bunch of things here, right? If we had the fine V-fib, we're going to shock. Huge difference. If we have the fine V-fib, we're going to give amiodarone. Huge difference. So for asystole, always check a second lead to make sure that it is asystole, because asystole is a rhythm with a poor prognosis. V-fib, it's still not great, but it's better. And there's much more we could do. And I just wanted to say a couple more things about these particular algorithms here. The only things that are actually shown to improve survival to hospital admission. So this just basically means they live long enough to be admitted to the hospital. They live long enough to get out of the ER. To improve survival to hospital admission. Two things. And those are the two things that we've been stressing. The first one, good quality CPR. And the second one is early defibrillation. And you can see that these things have been stressed throughout these algorithms, right? We want to make sure that we shock them right away, and so we put them on a monitor. And this calling a code thing really means get a crash cart here, get somebody with a defibrillator, and then good quality CPR, 2 minutes, uninterrupted. We want to minimize our interruptions. Also, we don't want to, we are always going to have the CPR guy switch so we can make sure. And we're going to monitor how good our CPR is with our capnography. We want to make sure that we're getting good waveforms here too. And early defibrillation. All these drugs and things, they've not been shown to improve survival to hospital admission. That doesn't mean that they don't. It just means the studies aren't there yet. But these are the two things that we're really stressing. Okay, so the next videos we'll probably take a look at symptomatic bradycardias and tachycardias. All right, thanks.